Now, here we have a very interesting HRCT of the chest, and we'll be discussing some very interesting things in this HRCT. Now, when we see this HRCT, we know that this is the left side and this is the right side. This is always the left side, this is always the right side. It is mentioned here that it is L and this is, here it is mentioned that this is right side and this is the left side. So, we know that this is left lung and this is right lung. Now, we always know that the normal lung parenchyma should be not like this, but still this type of or this much is we can consider it is a normal lung parenchyma where you can see lungs, where you can see bronchovascular markings, but there should not be very dense whitish patches or whitish dense fibrotic bands as well. And the bronchovascular marking should be infrequently present, means there should not be a significant presence of the bronchovascular markings. So if we, it's very difficult to find a good normal lung parenchyma, but I'll still show you that this type of lung parenchyma, we would consider that to be kind of normal because we can see there is no much prominent dilatation of anything, there are no whitish bands which are there, or uh, there is no any lesion into this space, there are no whitish bands, whitish lesions. Just compare this type of lung, the blackish radiolucent. This is comparatively lung, normal lung to this. See, there are so many whitish reticular bands. Here also, there are so many whitish, dense linings, which actually indicates that there is fibrosis into the lungs. See, this is normal lung. So in normal lung, basically, it has only alveoli, bronchovascular markings, and air. So if lung is not inflamed or if there is no significant fibrosis or damage or a patch, there should not be any whitish lines because whitish lines or radiopaque lines usually indicates fibrosis. So fibrosis will only occur post-inflammation. Wherever there is inflammation, that will be healed by the fibrotic bands. So what we can see in here, see there are so many whitish lines, which are thick whitish lines, and they are all arranged in haywire. These are not arranged in very routine way because we know that lung uh, the bronchovascular markings, they originate from this hilum and they spread to the periphery of the lung. So if we have to have a pattern, this pattern should follow from hilum to the periphery. But just see here, it is looking like a Maggie noodles. So there it is not a particular continuation from this to here. It is all the dense fibers are here, and these fibers are here also very much significantly present here, and up to the periphery also the dense fibrotic bands are there, which should not be there. Just compare this lung. See, we don't see much of a dense lines here, dense fibrotic bands. So we know that in here also we have so much of dense fibrotic bands, which suggest that the patient had extensive chronic inflammation into the lung parenchyma, which has caused the fibrosis and the lung parenchyma loss. So coming to other findings, which are, because there are so many good findings, ideally both left lung and right lung should approximately have same size or same volume. But if you can see here, as we know, this is left lung and this is right lung, because it is written it is right, it is written it is left. So just compare, this lung appears so much small and this lung appears so much large. This lung looks almost 2.5 times this left lung. So what is the problem, or where is the problem? Actually, the lung should not be this much small. The thing is, we know the mediastinum. These are the lung parenchyma, and this central structure is all mediastinum, where we have heart. So, this is two bronchi, because we can see the blackishness. This black is all air, and there is only one thing of this much caliber is trachea. So trachea has divided into left bronchus, right bronchus. So ideally this right bronchus should be here and left bronchus should be here, because the trachea is in the midline. So it should get divided into left and right bronchus. So trachea should have been in the center. The mediastinum should have been in the center. But here, no part of the mediastinum is on the right. The whole mediastinum is completely shifted to the left side. And we know if there is fibrosis or collapse, the lungs get uh, pulled toward that side. So we know that lung is extensively damaged, extensively fibrosed, and there is significant volume loss of particular left lung field, which is pulling the mediastinum and pulling the heart. This all is heart only, except this, which is trachea. So this is pulling the trachea, pulling the mediastinum toward the left side. Whereas what structures push the mediastinum is pleural effusion. So pleural effusion will be around the costal margin. We are not saying a single drop of pleural effusion also, or a tumor or a mass. So there is no mass. We can trace the lung up to the periphery, up to the rib margin. So effusion is not there, mass is not there. So the mediastinum shifting, heart shifting, and tracheal shifting is all because of significant lung parenchyma loss on the left side. We can see it here also. We can see the right lung. There is no left lung because this is all fibrosed. So whenever we say it is a fibrosed, it gets crumbled. So it automatically pulls the tissue which is present here. Here also we can see the right lung. This is the central trachea, and just see this is all part of mediastinum, which should have been actually here, but it is actually here. So it is all pulled toward the left side. This left-sided fibrosed collapsed lung is all pushing not only the mediastinum but the trachea toward the left side. So we can see that there are these dense white fibrotic bands which indicates that there is extensive lung parenchymal damage, which contributes to restrictive lung disease. There is left upper lung field fibrosis, most commonly because of the TB, because this patient was retroviral disease positive, HIV positive, and this patient had history of tuberculosis, pneumonia that was bilateral, which caused extensive bilateral lung parenchymal damage. So bilateral restrictive lung disease was there, and because of the extensive left upper lung consolidation getting complicated into fibrosis, that caused mediastinal shifting, trachea shifting towards the left side. There is one more interesting thing which I need to show is this, that we can see, just look this to at this area and this area. These three things. Actually, we can see that the black thing is inside, means this is air. This is air. The black is air because this is HRCT X-rays. Air looks black on HRCT or X-ray. HRCT itself is an X-ray only. So the black is air. It means this is bronchus, because in lungs air is present in alveoli and bronchus and trachea. So this is periphery, means this is not trachea. This is simple bronchial divisions, and alveoli will be very small. Yeah, alveoli will be much smaller than the dots that I'm putting. So there are crores of smaller alveoli in all these lung fields. So this will be very small. I cannot make the smaller dot than this. the alveoli will be that much smaller. So this is bronchi. So you must be wondering, so why this bronchus is this much prominent, and why the bronchus or bronchi are not visible here, or why they are not here, or this type of large bronchi, why they are not here, or why they are not here, or why they are not here. Though one is there, we can see here. So why these bronchi are not anywhere else? Here also, it is not. It may appear like this, but this here we can have some small bronchi. See this one and this one. So these are the dilated bronchi, and what we call it as is bronchiectasis. So what is bronchiectasis? Bronchiectasis is basically an abnormal excessive damage of the bronchi, and that is permanent damage of bronchi so that they are dilated. And once bronchi are permanently dilated, these patients are prone for recurrent infections, because we are not seeing any bronchi here clear cut visible, but here we can see they are thick walled. You just see the thick wall. This is the thick wall. They are so much thick walled, and their integrity is lost, the elasticity is lost, so the bronchi become permanently dilated, and these bronchi fail to throw out the secretions which are there. So these patients keep on getting recurrent lung infections, and these dilated bronchi tend to very commonly have sputum, expectoration, mucus secretions, and recurrent bacterial as well as viral infections. So this bronchiectasis is one of the very bad thing to have, and such patients should be always vaccinated, always every yearly with swine flu, because swine flu very commonly cause exacerbation of viral pneumonias or viral ARDS. So this is one of the very interesting HRCT of the chest, showing bilateral lung parenchyma involvement, extensive bilateral restrictive lung disease, severe left-sided restrictive lung disease with fibrosis, collapse, and mediastinal shifting as well as tracheal shifting, along with few patches of bronchiectasis as well. And that was in a patient who was immunocompromised and with a history of tuberculosis in the past. So this is for all, and thanks for your kind listening.